Good afternoon, everyone, and welcome to the Cancer Support Community's educational webinar. I'm Kathy Riley, the Associate Director of Programs at CSCLA, and I'm honored to welcome you to this week's webinar titled, Can a Low-Carb Ketogenic Diet Actually Be Good for Cancer? Before we begin, if this is your first time joining us, the Cancer Support Community Los Angeles is a premier nonprofit organization providing vital social and emotional support to families facing cancer. And that includes patients and caregivers and their loved ones, all at no cost. Our programs include support groups, healthy lifestyle classes, social activities, and educational programs such as this one. And if you would like to learn more about our services or watch past webinars, you can visit our website at cancersupportla.org. And before I introduce today's speaker, please note that your video and microphone are automatically disabled for this webinar. You may, however, enter your questions into the Q&A feature found at the bottom of the Zoom window at any time. And we really welcome questions from all of you, so please use that feature. And questions will be answered at the end of the presentation. We may not be able to get to all of your questions today, but our presenter will share his contact information at the end of the webinar. Stephen Freedland is Director of the Center for Integrated Research in Cancer and Lifestyle and Associate Director for Education and Training at the Cedars-Sinai Samuel Oschin Comprehensive Cancer Center. He is also a professor in the Department of Urology at Cedars-Sinai in Los Angeles, California, and holds a staff physician appointment at the Durham Veterans Affairs Medical Center in Durham, North Carolina. He has published over 700 articles and served on numerous American Urological Association and American Society of Clinical Oncology guideline panels for prostate cancer. Dr. Freedland earned his medical degree from the University of California, Davis, and completed a residency in urology at UCLA and a fellowship in urology, actually in urological oncology at Johns Hopkins. And it gives me great pleasure to welcome Dr. Stephen Freedland to our webinar today. Dr. Freedland.
Great. Thank you so much for having me, Kathy. It's great to be here today, talking to you all on a really important topic here. So let's get the slides going here. Give me 1 second. We're gonna share this, and then we're gonna switch. All right. Can you guys see everything okay?
Yeah, we can see everything fine.
Okay, great. So thanks so much again for having me. And you know, it's really interesting as we start to think about one of the first questions I often get from cancer patients, maybe not necessarily the first, but you know, once we've kind of gotten over the shock, they have cancer and what we're going to do about it. One of the questions I get, well, what should I eat? What can I do to kind of help fight this cancer? And amazingly, we really don't have a good answer to that question. I mean, it's a very simple question. We should know the answer to that. And lots of people will give you advice, they'll give you opinions, they'll couch it as if we know, well, if you just do this, you know, things will be better. But if you really delve into it, we don't know. And so that's what I want to talk to you today is some of the data we have emerging. And, you know, I say emerging and because it's still ongoing research, is can we go to a low carb ketogenic? Ketogenic is also very high fat, which is, you know, been told for a long time is bad for us, can actually be good for cancer. And what I want to go through is talk about clinical trials. I'm going to talk a little bit about prostate cancer. I am a urologist, so that is my forte, prostate cancer. And then I'm starting to dabble in brain tumors because I think diet's important in there as well, and then conclude with a summary. So when we think and ask the questions, do we need clinical trials? I mean, don't we all kind of know what to do? I mean, we learned early on back in the 60s Smoking was bad for lung cancer. There was never a randomized trial of that, right? We didn't tell this person you should smoke and this person not to smoke. Let's see what happens. We just saw it was pretty clear. Smokers were getting a heck of a lot more lung cancers. Maybe there's something there. And, if we really think about it, there's never been a randomized controlled trial of whether parachutes work. And certainly if there was, I would not want to be in the placebo arm of that trial. So the question is, do we need trials for diet? Don't we all kind of know what a healthy diet is? And so I would argue that the answer is no, that we don't. Let me give you an example of this. So there's certainly, one of the big things when I was growing up, in the early 70s and mid 70s, and certainly by the 80s, is we were told fat is bad. Fat is bad. Fat leads to cancer. Fat leads to obesity. Fat leads to heart disease. We really got to cut out how much fat we eat. And so indeed, there was some data to suggest that eating lower fat may lower cancer risk. But the problem is what we did is started eating a lot more other things. And, basically we started eating fat-free ice cream, fat-free candies. Remember one year, my daughter, who's 21 now, came home from Halloween, and on the package of her Skittles, big branded things were a fat-free food. I mean, it must be healthy for you, right? There's no fats. Who cares? It's pure sugar. It's Skittles, but it must be healthy. There's no fat. So, and the challenge is people back in that day who did eat less fat, they exercised more, they ate more fruits and vegetables. They actually ate less sugar because they were doing it to be healthy. They weren't eating low-fat ice cream back in those days. And so we got this idea that fat is bad for us. So actually, the government ran a very large study, randomized almost 50,000 women. This is a huge study. I mean, you think about 50,000 women postmenopausal. They were either told to follow a low-fat diet and eat more vegetables and make no change. And everyone's like, why are we doing this study? Come on, we know what's going to happen. They're going to get all these less cancers and less heart disease. And, do we really need to do the study? And some really smart people that said, yes, we do. We do need to do this study. And when they did it, they actually found there was no difference in breast cancer risk, no difference in colorectal, no difference in any cancer, no difference in heart disease, stroke, diabetes. You go down the list, negative, negative, negative. And so at the end, maybe just eating a low-fat diet may not be the answer. Or people said, well, they didn't follow the diet strong enough. They weren't strict enough with the diet. We didn't do it long enough. We didn't, if you're doing it, you have to lose weight to get the benefits. And so it's easy to come back, but I would argue for many of the things, we don't know the right answers for diet. And so this epidemiological data, kind of observing the world, does not always give us the right answer. Diet, lifestyle, very, very complex. And so ultimately, I think what we need to do is we need to get into the mechanisms and really understand at a molecular level how diet may work. And to do that often requires animal studies. We can actually take tumor cells, feed them different nutrients in a petri dish. We need to do smaller, intermediate endpoint-driven trials. So we can't be doing 50,000 trials of every possible diet. You need to do 50 patient trials and see, can you change this protein? Can you increase expression of this gene? Can you lower this? That may give us some hints that we're on the right track before we launch that next big study. And then we really need to understand how to do these in the real world. Maybe the compliance wasn't good enough. Maybe we shouldn't have started it when they were postmenopausal. Maybe it was premenopausal. Maybe it was at puberty that we needed to start these trials. Maybe in childhood is when we really need to be intervening to have the impact on adult cancers. And so at the end of the day, you can't study every diet and ask every question you could possibly want. So today we're going to talk about low-carb diets. We're going to talk about ketogenic diets. I am not here to tell you that is the best diet. I'm not here to tell you it is the only diet. What I want to show you is the data we have developed doing these smaller, intermediate endpoint driven trials, randomized trials, and what this may mean for you and your journey and your life. So if we look at low carb diets and ketogenic diets, and they're in the same family. They are different. Low carb just tells you what you not to eat, but really doesn't give you limits as to what you can eat. And fats and proteins is kind of as much as you want. Keto is very high fat, moderate protein, and very low carb. So a lot of low carb diets aren't quite keto because they have more protein, but again, they're in the same family, if you will. And so this is what we see in both the real world and in our clinical trials, is that patients lose weight. And that's probably a good thing for cancer, but even that is not 100% incontrovertible. There's some debate about that. We certainly lower sugar levels in the body. We lower insulin levels. We reduce inflammation. We alter epigenetic signaling. Big fancy words, but basically you are who you are because of ultimately your DNA, but not every gene is active in every cell. And what determines whether a gene is active in this cell or that cell, or highly active or slightly active, often is called epigenetic signaling. It controls how genes work. So DNA may give you the blueprint of the genes, but how they're actually translated into your body working is via epigenetic signaling. We alter the microbiome, that's the bacteria in your gut. Probably other places in the body as well have microbiomes. Prostate, some data that breast, the bacteria can kind of develop and grow in the breast, not an infection, but that they tend to live there. Then importantly, then we can actually, with the low carb and the ketogenic diet, it's quantifiable. So with keto in particular, is we can measure your ketone bodies. And there's a pretty good correlation between your compliance and your ketone bodies. So it's very tough with diet to measure compliance. And are you really taking the prescription, the intervention, if you will? If it's a drug, I can measure levels of the drug in your body. I can see, did you take the pills? Diet, not so easy. But that's one of the nice things about keto is we actually can measure it and quantify it. So let's talk about prostate cancer, one of my favorite topics to talk about here as a urologist. And the question is, do these diets, low carb, actually benefit men with prostate cancer? And so this is the carbohydrate and prostate study 2. So if you're listening at home, you're going across this carbohydrate and prostate study 2, there must have been a 1. Well, there was, and just for the sake of time, we're not going to discuss it, but it was in men starting hormonal therapy, the 1, and we showed a lot of those benefits I told you about: lowering insulin, lowering sugar, weight loss, improving inflammation. That was stuff we showed in CAPS 1. But here, the question is really, what does it do to the tumor? So this was a randomized trial of very low carb, 20 grams of carbohydrates a day. So basically 80 calories. So anything you think of as a carbohydrate, cookie, cake, candy, out. Even complex carbs, you might think whole wheat bread, brown rice, etc., out. Fruits, out. Too many carbs in fruits. And you can say, whoa, fruits are good for you. Fruits are good for you. And I'm not saying they're not good for you, but this is what we did in the study, is we eliminated fruit. We eliminated alcohol because that's a carb, to the degree that we could. Not everyone listened to us, but we tried. And basically, we took men who had surgery or radiation for their cancer, and it didn't do the trick. The cancer was back. We can measure that cancer coming back by the PSA level, because after surgery, this is how we screen for prostate cancer, the PSA blood test. After surgery, radiation should be effectively 0 or very close. And so if it's not 0 and rising, we can measure the rate at which it rises. And the faster it goes up, the PSA doubling time, right here, the doubling time, is a measure of how fast the tumor is growing. So we thought we could slow down this doubling time. We looked at some secondary outcomes: weight loss, resting metabolic rates, others. And we had planned to do 60 patients. We ended up doing 45. and stopped the study. A lot of reasons why, which I'm happy to, if it comes up in the questions, to go into the details. But these are the data we have. So we enrolled 78, 57 got randomized, and about equal to low carb and standard diet. And the first thing you notice is a 6-month study, and the standard diet, 4 patients dropped out of the study, 4 out of 30. In the standard diet, sorry, my mouth is getting dry here. In the standard diet, actually 8 patients, twice as many dropped out, with the number one reason is they needed treatment for their cancer. They couldn't wait 6 months. This group was more likely to be able to wait 6 months. Twice as many people dropped out of the study because their cancer was progressing. So already a little sign that there may be some benefits. But then the question is, what did they eat? And we had them self-report how much, what they ate. And if we looked at carbohydrates here at baseline, it's pretty similar. And after 6 months and the low carb, they were down about 37 grams. Again, we told them 20, and they kind of listened to us. I mean, they dropped a lot, not quite as low as we'd want. Again, compliance is difficult. Were they just telling us what we wanted to hear at this point? Obviously, who knows? The control, and this is one of the things that we worried about, was imagine I'm telling you about this trial and say, look, I think sugar's bad. I think sugar makes your tumor grow faster. We're doing this study because we want to cut out sugar, see if that can slow your tumor growth. And we're really excited about this. Do you want to be a part of our study? Patient says, sure, I'm happy to be a part of it. And you flip a coin and it comes back heads, and you go, oh, actually, you're on the control arm. Sorry, don't make any changes in your diet. Don't change anything. And so the question is, do they actually change their diet? And the answer is not really, not a lot of change in the carbohydrate intake. If we looked at protein, it does go up a little bit, not tons, does go up. It was not statistically significant. It's not a huge study, but again, we're not seeing that they're eating nothing but steak all day long. The amount of protein did not really go up. And we look at fat intake. We encourage them to do what we would argue is perhaps healthier fats. So kind of avoiding saturated fat. So more skinless chicken type things, cold water fish, grass-fed beef, things that are going to be lower in saturated fat. But the total amount of fat, again, it did go up a little bit, but not statistically significant. And so the question is, what did this do for the tumor? And, that's the key question. And I'm going to walk you through this here, is if we just say, how long did it take the PSA to double? In the control group, it was 15 months. In the low carb group, it was 22 months. So a little bit longer, but not statistically significant. But if we just say, did this doubling time, the rate of this PSA going up, did it slow down? You imagine half the time it should slow, half the time it gets faster. It's kind of noise. That's what we saw in the control group. About 40% of the time it slowed down versus almost 3/4 of the time in the low carb group. So getting towards statistical significance. But then when you do a small study, even though you randomize patients, each patient, I flip a coin, heads versus tails, left versus right. At the end of the day, when you do that, the group on the left may not look exactly like the group on the right. If you do a big enough study, it will look like that, but we only have 20 some odd people in each group. It doesn't always look that way. So we realized there were some small imbalances between the groups. For things that we think are important, the race of the patient, whether it's surgery or radiation, what their doubling time is coming into the study. And so when we adjusted for those factors, we actually found the control group was doubling in every year, every 12 months, versus over 2 years for the low carb group, which was statistically significant. And if anything, what happens is when you lose weight, which I'll show you in a second, you kind of concentrate your blood volume. So it seems like the PSA is going up even faster just because you're concentrating it. So when we adjust for that, we get just over a year versus 2.5 years here. Again, highly significant in a admittedly post-hoc exploratory fashion. Certainly zero evidence that this diet's actually bad for the tumor. And if anything, it may actually be good. If we looked at other things here, so if we looked at the weight loss, and then control, again, there's really no change in weight, negative 0.6 kilos, 1 pound over a 6 month, not a great change. Whereas the control group lost over 24 pounds. They were losing about 25 pounds. We did not tell them to lose weight. We did not tell them to eat less. We didn't even tell them to exercise. All we did was say, don't eat sugar. Do not eat carbohydrates. That's it. Outside of that, eat whatever you want, exercise whatever you want, eat as much as you want. We don't care. Doing that one simple change, 25 pounds of weight in 6 months. And you think, wow, they're eating all this fat, must be horrible. Their cholesterol must go through the roof. Not really. Cholesterol went up a little bit versus, again, not really much of a change, but not statistically significant. And if anything, most of this cholesterol change was actually HDL, was your good cholesterol. If we looked at triglycerides, the measure of kind of diabetes response, it went down. Glucose didn't change much because they were, by and large, non-diabetics. But your HbA1c, for those who are diabetic, very familiar with this, went down 0.4, which is actually what we see in clinical trials with patients on a very intensive dietary intervention. So very, very impressive in terms of it doesn't seem like much, 0.4, but it's actually a big difference in terms of lowering diabetes risk. And so one of the questions that comes up from these studies is, look, you're eating all this food, all this fat. Come on, it's got to be bad for someone. It's got to be bad for your heart. I mean, that's what fat is, goes to your heart. So we looked at that. We looked at the risk of cardiovascular disease, heart problems. There's calculators from Framingham Heart Study and other things. We could plug in the numbers from our patients, the lab test. So this is estimated cardiovascular risk. And what you see is there's two different ways to calculate it, whether you use actual lipid levels or by body mass index. But either way, it's going down with the low carb and trending towards significance versus highly significant here. So if anything, lowering cardiovascular risk. And we looked at lowering metabolic syndrome, which is a composite term of obesity, high blood pressure, high cholesterol. And when we put it all together, again, many, many benefits to the metabolic health, maybe to the tumor as well. So thinking about where do we go from this, I was very fortunate to meet Dr. Jethro Hu at Cedars, LJ Amaral, dietitian, several others who had an interest in brain tumors. And to me, this was one of the beauties of being at Cedars, me being a urologist, focusing on prostate cancer. No one batted an eye when I said, look, I'm now doing brain tumor. I'm working with Jethro and LJ and others. Like, great, that's wonderful. It's just the kind of spirit we have at Cedars. And from the research perspective, I'm not seeing the patients. That's still Jethro. But we recently got a very large grant from the National Cancer Institute to test a ketogenic diet. So now not just low carb, but really high fat, moderate protein for 18 weeks under a dietitian supervision, very, very close. And we're taking patients newly diagnosed with brain tumor, very, very aggressive disease, very poor prognosis, and saying, can we improve that by putting you on a keto diet? And it's relative to a control. And we think by lowering some of the metabolic signaling, the insulin, the glucose, different things, we can actually boost the immune system as well, changing the gut microbiome, lowering inflammation, that ultimately we can improve overall survival. Kind of the holy grail, making people with this horrible disease live longer. We think we can actually improve their quality of life, cognitive function, and activity level. So it's ambitious, but that is our goal. We are taking patients newly diagnosed. We're consenting them and randomizing them. They're randomized to a standard of care, which is radiation, chemotherapy, followed by more chemotherapy for 18 weeks. on the ketogenic diet and assessing overall survival. And this is an N of 1, a patient who you can see a big tumor here, gets surgery, so maybe that did it. He got chemotherapy, radiation, but also the ketogenic diet. You see afterwards, tumor almost gone. So that is the hope. Again, myself, Dr. Hu, LJ, many others up here. So what I would say is, in conclusion, we do not know the best diet for cancer. And anyone who tells you they know is lying to you. We have opinions, we have thoughts. Nobody knows the best diet. And that's why we're doing these clinical trials, to really figure it out. Our studies in prostate suggest there may be benefit, and we're now testing it in brain tumor. We have some preliminary data that may be beneficial, and that's why we're now doing the randomized trial. We do have a study in prostate cancer. It's now open, looking at a fasting mimicking diet for patients with metastatic prostate cancer. If anyone's interested or knows of people, I'd be happy to talk to them or see them. And we actually have a study ongoing of walnuts. We have a study for patients undergoing surgery for prostate cancer. Later this year, we're going to be starting a study of urolithins, which are actually the active metabolites of pomegranates. So we're taking the active part of a pomegranate and trying to condense it down to a pill. We'll see if that works. And again, for patients undergoing surgery. But ultimately, I would put in a push that we need to be participating in trials. You yourself will get the best care. Even if you're on the control arm, you're going to get a coordinator calling you frequently, checking in how you're doing, reminding you for your appointments, blood draws, scans. There's actually data that people who get onto a clinical trial, even on the control arm, live longer than people who don't go on clinical trials. So it's going to help you. We're going to advance the field. And someday, we may actually be able to answer that. What is that best diet for cancer? Lots of people involved in these studies in the breast and the brain. Most importantly, I want to thank the patients and their families for believing in us and helping us move the field forward. And I'm happy to take any questions. Get out of the presentation mode here so I can actually see the screen. I will stop sharing, and it looks like we do have some Q&A here. All right. So I'm just going to read these as we go through. If high blood sugar, borderline diabetes is caused by medication, will low carb or ketogenic diet help, especially if you already have pre-diabetes? The answer is yes. Regardless of the reason you're on, have that pre-diabetes. We've seen patients reverse their pre-diabetes. We've seen patients reverse their diabetes, frankly, by going on these diets. Even if it's caused by medication, steroids would be a common medication that can cause that kind of high sugar levels, and the diets can help overcome. And I'm not saying that diet is magic, it cures everything. It's not. I think it can help. I think it can be a complementary therapy, not necessarily an alternative therapy. So you may still need medication for the diabetes, different things, but I think it can help, even if it's drug-induced sugar problems. Is low carb good enough, or do you have to go all the way to keto? Great question. The short answer is we do not know. I do think my opinion, and I'm very careful in what is an opinion versus a fact, that weight loss is a key mechanism by which many of these diets work. If we can get severe weight loss and a healthy sort of weight loss with our low carb, you may not need to go all the way to keto. But there's no studies I'm aware of that have compared low carb as the way we've done it. For those familiar with Atkins Foundation, it's essentially phase 1 or induction, not even phase 1, induction phase Atkins for 6 months. I don't think there's a major difference between that and keto, but no studies to my knowledge have actually directly compared those two. How about a plant-based diet? Is it not better than the diet you talked about? So there's zero data to say it's better than what I've talked about. Zero. A lot of people will claim it. Again, they are using opinions. They're not using data. Okay. To my knowledge, there's not been good head-to-head studies of plant-based versus keto, kind of the two extremes. A lot of people will point to the China study and different things. None of that's ever been published. It's not peer-reviewed. It's not actually even randomized trials. Actually, the largest observational study that was done, it was called the PURE study, published in Lancet, which is one of the premier journals in the world. People from 4 different continents, I think it was 170,000 people. They actually showed that people that ate more meat actually lived better and had lower risks of cancer, lower risks of heart disease. Again, it all depends on the type of meat you're eating. That's observational data, so take it with a grain of salt, right? We got to do the trials. But I have nothing negative to say about plant-based diets. Despite all the enthusiasm, the literature, the randomized trials of them are very, very scant. There was a recent review article about them in one of the prostate cancer journals, and they touted, look at all these studies, plant-based diet is so great. And actually, they quote a lot of studies of Mediterranean diet, which certainly has meat in it. They had other ones that encouraged high fish intake. They had almost no studies in their review that were truly pure plant-based. So I do think plant-based probably is a very healthy approach. If someone's taking that approach, I certainly don't try to discourage them, but I just want to be realistic if we don't really have the full data that people think we have. Any trials for breast cancer? So we had some of these low carb trials going on for breast cancer. They have subsequently closed, but we are always exploring new trials. So reach out to the breast team at Cedars. Farron Amercy and Monica Mita are two of the one's a breast surgeon, Dr. Amercy, and then Dr. Mita is a medical oncologist. Both have worked with our team doing dietary trials, and I think can direct you to the right trials. What were some of the limitations of the study? So yeah, I mean, so the challenge is with the prostate stuff, first off, they're small studies, so they're not definitive. We're trying to make the best interpretation we can from the data. I think they clearly showed the safety. They didn't show that the benefits as strong as I think we would have if we'd had bigger studies. And most patients don't want to change their lifestyle. They don't want to change their diet. They want to take a pill, or they want to change their lifestyle, but they're not willing to be randomized to a group that's not being asked to change their lifestyle. So it becomes very, very difficult to actually study, do these changes actually make a difference? We need a control group. So the low carb, we started offering, everyone's going to get the intervention. You're either going to get it now or 6 months from now, but everybody will get it. And I think that helped with enrollment. But these are difficult studies to do. I mean, CAPS 1 had about 40 people, CAPS 2 was about 45, we had a CAPS 3, which had about 20 people. So we've randomized about 100 people, but that's over the course of over 10 years worth of work. The brain tumor, we're targeting 170. We already have 8 enrolled so far. So we're doing well, but these are tough studies to run. I would say is the biggest limitation. Would liver flukes, lesions, mold, candida, SIBO make cholesterol higher? Mine normally average around 200. I've been eating 1 or 2 eggs a day with veggies, no sugar. Cholesterol is up to 275. So the short answer is I do not know. I am an oncologist. I deal with cancer. So that would be a great question to ask a dietitian, to ask an internist. I don't know the answer to those questions. Cholesterol is there's both dietary cholesterol, and then there's cholesterol your body makes, which is often driven by your genetics. So certain people, just based upon genetics, have high cholesterol. You can eat perfectly, do everything right, exercise like crazy, and they're still going to have high cholesterol. And that's where we need medications. There are some people whose high cholesterol is dietary induced, and cutting down on how much you eat will lower it. So the eggs tend to be high in cholesterol. So it's certainly possible that that may be contributing. I don't know, and that's where you really, you need some experiments, kind of using yourself. Let's try eating the eggs. Let's try not eating the eggs. Let's exercise. But ultimately, if you're living at those numbers, I think that's where we start to talk about medications, and particularly statins. Is there a recommended vegetarian diet you can recommend without meat? Yeah, and that's what I say. I think a plant-based diet is very is perfectly healthy. I think we need to be careful though when we talk about a plant-based diet or a vegetarian diet. Is if you look at a Twinkie, it's pretty close to a vegetarian diet. It does have some lard in it, so if you take out the lard, but chocolate chip cookies are vegetarian. There's no meat in a chocolate chip cookie. It's honestly vegan. There's ways to make it vegan, but the point is you can have a vegetarian diet that's still not healthy. And just because you're avoiding meat doesn't mean you're necessarily going to be eating healthy. It's still avoiding sugars, cookies, cakes, candies, that type of stuff. So I think what I prefer to call it rather than a plant-based diet is a whole food plant-based diet. That you are eating foods that are actually growing in nature. You could find them in nature, or just a whole food diet in general, or you're eating animals running around nature, eating their natural diet. So not farmed, corn-fed beef type thing, it's grass-fed. And so I think that's probably the best way. And whether that goes more towards the vegetarian, whether it goes more towards the keto, or you're mixing both, I think is perfectly fine if we can get to that whole food concept, not things out of a box. What's the best dietary change that a vegetarian can make to get into a ketogenic state? My experience is almost impossible for a vegetarian to get into a keto state. And we actually exclude in our keto diets and our low carb vegetarians. It's just you can't get enough proteins. There's legumes and beans and nuts and different things, but they all still have carbohydrates in them. And if you're eating the vegetarian / vegan diet, I think those carbohydrates, they tend to be complex carbohydrates. I think they're perfectly fine in that context. But I think it's almost impossible, and I've not heard of someone being a vegetarian and being keto. They're almost mutually exclusive in that sense. Can keto low carb diet help prevent getting cancer? Wow, that's the $64,000 or $64 million question. We don't know. We don't know. There's certainly data that in healthy people, higher insulin levels, higher obesity rates are linked with cancer. And we know a low carb keto diet. And again, I'm not saying there are other diets that don't do this, but we're just talking low carb keto, that they will lower insulin levels, they will lower sugar levels, they will reduce obesity, and there's every reason in the world to think that they can prevent those cancers, but we don't know that. So anyone who tells you that they do, again, is lying to you, or they're spinning their opinion, their belief, their hope as fact. We do not know. I would love that to be true, because I love it for whole food plant-based. I'm not a one-trick pony. I want the best lifestyle, and it's going to vary for each patient, but I think so, but I don't know. Great question. Any thoughts on supplemental, the median chain triglycerides in cancer? Not a lot have been studied on that. So I mean, the short answer, there's been a lot that have been looked at just in supplements in general. I know those are a little bit different. And, supplements in general have pretty much failed in almost every cancer trial. They've really been looked at in scale. So we do not recommend any supplements to our patients at all. Particularly if they're getting radiation therapy, it could actually minimize the benefits of radiation. So for the NCTs, I'm not aware of any studies, but I'm sure there are studies out there that I'm just not aware of. So I don't personally have any thoughts, but I'm sure there's some literature out there. Would an adrenal benign tumor cause high cholesterol? I mean, a lot of the adrenal benign tumors can make hormones and they can alter things. I wouldn't think necessarily high cholesterol would be one of those things. That's usually not one of the hormones they're making. There's not as many hormonal regulations of cholesterol. It's more dietary, genetics, other factors. So I would guess no, but again, you would probably want to ask an internist that question. Do you know if cancer is contracted due to inflammation? So it's a great question, and you put in the contracted in quotes there. So there is data that higher inflammation in general, and everybody defines inflammation differently, and that's part of the challenge. There's no easy blood test that measures inflammation because it's a very complex concept. But there's certainly data that inflammation can lead to cancer, certain cancers. Infections can lead to cancers, and we think they do it by creating inflammation. And inflammation is your inflammatory cells running around trying to kill bacteria and viruses. And the way they do that is they create what's called reactive oxygen species, ROS or ROS. And that ROS is meant to kill bacteria, but it also can damage normal cells. And it particularly damages the DNA. It can damage that epigenetics that we talked about, how DNA is regulated. And before you know it, you have genomic alterations, your genes get messed up, you start turning on genes that you shouldn't be turning on. And lo and behold, over time, years, typically decades, if not, that can lead to cancer. So yes, inflammation is certainly involved in many, many different types of cancer. So, in terms of Seyfried's work, so Thomas Seyfried is up in Boston. He's actually done a lot of the pioneering work with ketogenic diets and brain tumors. There's a lot of interest now in glutamine. There is some work being done at Cedars-Sinai looking at glutamine. It's not clear whether we need to block it or actually give higher levels of it. There's some controversy on that. I think, there's a lot of, we don't know about tumors that are coming out now about pulsatile treatments. We're actually seeing this in prostate cancer, where the treatments for advanced prostate cancer have been for years to block testosterone. Testosterone fuels the tumor, let's block testosterone. We're now actually taking patients with very late stage advanced prostate cancer and actually giving them high dose testosterone. 20, 30 years ago, it would have been considered malpractice. We're actually finding it works for some of these patients. So this idea of pulsatile treatments, I think we're going to learn a lot more about it. It makes sense. And that's where ultimately, again, diet is not going to be the end all for every tumor. We're going to need to combine it with standard treatments. The hyperbaric oxygen, I'm a little skeptical of, but glutamine is something of tremendous interest to some of our collaborators at Cedars. So I think the future is still a long ways off. We've got a lot to learn. Well, low protein, slow cancer growth. Doesn't matter which amino acids. So there is some data that cutting protein will slow tumor growth. A lot of people have looked at methionine, which is the first amino acid that gets put onto every protein. People have looked at some other ones, glutamine among them. So the short answer is, your body is amazing at its ability to adapt to what you put into it. You think about over evolution, we evolved in all kinds of starvation environments, and yet we're still here. Tumors need lots of protein. They need carbohydrates to grow. They need fats. So if you can deprive one of those three, I think you have a decent anti-tumor diet. So low protein has been looked at. The keto low carb focuses on low sugar. The vegetarian tends to focus on low fat, like extreme low fat. And so I think if we can limit something, we're probably going to be pretty good at blocking tumor growth. Will there be follow-ups on the 2020 study to verify the conclusions weight loss will last? So I'm guessing you're talking about the prostate stuff. So it's interesting. We did follow up those patients a couple of years later and say, what are you eating? And what we found is, we had a hard time tracking everyone down, but the ones that we did, to a large degree, they seem to go back to their pre-trial eating habits. I certainly talked to some of those patients. They're still in my practice, that their diet, they say, has forever changed, but not drastically like it was in the trial. And I think that's, the challenge is, I have patients all the time that you have to go on a medicine because they're having problems peeing at night. And, they have a slow stream, so they go on the medicine. And they ask, how long are you going to be on this medicine? Am I going to take it for 6 months and then I'll be cured? No, you stop taking the medicine and it's going to stop working. And I think it's the same with diet, is if you stop following the diet, it's going to stop working. And so one of the things I'm very intrigued about is, can we combine diet with, for example, radiation, and synergize, actually make radiation more effective by being on a diet just for those couple months you're getting radiation, and you get those lifelong benefits. Again, a lot of unanswered questions. I've been on strict keto for more than 30 years. I belong to a whole group. I'm happy to share what I could do. Someone like me moves towards your studies. The answer is yes. We're interested in everyone. The questions we're asking now is, can we take someone who's not on keto, and by putting them on keto, make a difference? When you're 60 years old and diagnosed with cancer, is it too late? So other people have looked at those who've been on this diet for 20, 30 years, this diet for 20, 30 years. What are the differences? So I think as we start to think about those kind of studies, but I'm always interested in talking to people about what their experiences are, what's made them stick with it, what's worked for them, any tricks of the trade. So appreciate you sharing that. What is the mechanism by which low-carb keto can reduce cancers? We think by lowering insulin, lowering sugar, so lowering the stimuli for the tumor to grow, reducing inflammation, improving the microbiome to try and improve the immunity. You think about, you have cells that go rogue all the time and turn into cancer. Your body has very good mechanisms to try and eat up those tumor cells before they get to a real cancer. So if we can improve what we call the immune surveillance, the body's ability to eat up those abnormal cells early, we can prevent cancer. So I think there's several different mechanisms by which it can work. Was carnivore similar to keto? Essentially, yeah. Carnivore is pure meat based. So it's going to tends to be more high in protein. So I think that's more in the low carb camp. But again, we're in the same family. And with the carnivore, you just got to make sure there's certain vitamins that we get, and just make sure. So for people that are on these kind of extreme diets, you might want to think about a Centrum Silver type thing, one supplement, not overboard, not going crazy with everything, but just making sure you're getting all those different nutrients that you need, vitamin C and other things. The 20 carbs were total. So rightly or wrongly, it was total. My name is Annabelle. I'm the clinical nutrition manager at Providence St. John's. Yeah, no, I would love to talk to you. Feel free to reach out to me. My email was up there. It's Stephen with the ph.freedland at cshs.org. And feel free to reach out to me, and happy to chat. We have a whole team of dietitians, coordinators, and everything. So I've been diagnosed with triple negative breast cancer. Sorry to hear. That's a tough one. But again, I think if I'm not mistaken, you're the person on keto, and you know, I think something with diet we need to think about is, there's a study that was done by Bert Vogelstein, and it was at Hopkins. It was very enlightening and scary at the same time. And basically, the conclusion of that study, I'll boil it down to, is 50% of cancers just come from bad luck. Just a gene got turned on. There was no inciting incidents. You didn't eat anything wrong. You didn't smoke. You didn't pick the wrong parents and have some sort of genetic predisposition. It's just bad luck. And I think that's the moral, is we can do everything right and still bad things can happen. But what we do know is if you do things right, avoiding the obesity, whichever diet you choose to get you there, exercise, don't smoke, limit alcohol, try to limit stress, sleep well, have lots of social connections, do everything right, we're going to reduce the risk of many different cancers, many different elements. We're not going to prevent everything. Are things like intermittent fasting or fasting intermittent diet seen as beneficial in cancer support, or not enough research? So we're studying it. So the fasting mimicking diet, which is 5 days a month of extreme fasting, the rest of the month you eat what you want, has been studied in breast cancer with some benefits. We're studying it in prostate. We have a group at Cedars that's doing a colon cancer trial for time restricted eating, also known as intermittent fasting, which is basically limit how many hours during the day that you're going to eat. That's actually been expanded to breast cancer. Someone mentioned about breast cancer. I forgot to mention that's recently been expanded to breast cancer. So we're opening new trials all the time, explore what we have. If you're not sure where to start, hit me up, send me an email, steven.freedland@cshs.org. I'll get you connected in the right place. And if we don't have a trial, we have dietitians, we have people that are happy to help. Finasteride, I really want to stop. What happened to my PSA? Basically, PSAs typically will double when you go off finasteride, but I wouldn't worry so much about PSA. The PSA is just a marker. It measures prostate size more than anything. And if you want to go off it, I would say go off it if otherwise safe. If inflammation could lead to cancer and stress can reduce inflammation, it's not reasonable that stress can indirectly cause cancer. Yeah, no, I think there's a lot of increasing data. When we think about, for example, when we talk about different racial groups, the Black men are at higher risk of X, white or Black women are at higher risk of X, Y, Z. A lot of that finding is now coming down to the social determinants of health. It's not the skin color, it's not the genetics. It's a group of people that by and large have lower socioeconomic status. They undergo systemic racism, and there's a constant chronic stress and anxiety that these people experience. So there's a lot of research now going into chronic stress, anxiety, social deprivation, lack of social support, that all seem to, again, we don't have randomized trials. We can't change people's, I'm going to give you $1 million and see what happens to your cancer risk. That would be a great study. Again, I'm not sure I want to be in the control group, but there's increasing data suggesting that they may link with cancer. Any thoughts on how cancer is often followed by cachexia? Yeah, so in advanced cancer, you start to make particular hormones, cytokines. TNF alpha is the most common tumor necrosing factor alpha. It's kind of the body's way to help fight the cancer. It's a response to the cancer, but part of what that does is it lowers appetite and starts to break down your muscles. So as a late stage manifestation of cancer, you often see this cachexia, weight loss kind of wasting away. And so that's why in those patients, I wouldn't do a weight loss trial, right? I mean, they need nutritional support. They need to gain their weight. So different interventions, different times of the disease course. Only a few minutes left. We'll try and go quick. What do you think about intermittent or extended fasting in combination with low carb? I think it makes a lot of sense. Walter Longo has started to move, from my understanding, more towards, and he's one of the godfathers in this fasting mimicking diet, to when you're not on the diet to be on keto. I think it makes a lot of sense. We need more research. In regard to rectal cancer, do you know anything about this? Been plant-based, my whole food. Part of the logic is that animal protein takes longer to digest, isn't good for a colon rectum. Too much fiber. So red meat has been linked with colon cancer. There are certain carcinogens in it. Fiber is going to help move the poop through quicker, so you get less contact with the colon thing. So I think in general, in terms of colorectal cancer, which is predominantly colon, diet plays a large role. And there you probably want more of a high fiber or whole food kind of concept. Does fasting mimic dieting make chemo more effective? Great question. There's some certainly animal data to say yes. The human data is extremely limited. Short answer is we don't know. I got cancer from hernia mesh. I went on a special diet with juicing, green veggies, moderated no sugar, eating veggies, sauna, and now in remission, osteoic supplements. That's great. And I think that the challenge is, you know, and I'm first off, I'm happy for you that you were able to do that. I will put my email. I don't know if anyone can see this, but I will put it here. You know, and the challenge is, again, there's lots of people who did everything right and still got cancer. There's people who did it wrong and got a good outcome. And I appreciate you sharing your experiences for sure. I don't want to deny anyone their experiences, and everyone's experiences are valuable. But it's always hard to say because one person did X that means that's the right way to go. It's intriguing. So it means something we need to look into further. So rapid 1 hour, it goes quickly.
Yeah, that was really a rapid 1 hour. Thank you so much for fielding all of those questions. We really appreciate you, the meaningful presentation, the breadth and the scope of everything you covered. Thank you so much.
Yeah, no, my pleasure. It was great to be here.
And I want to let everyone know that Dr. Freedland has graciously, generously offered to share his slides. If you would like a copy of today's slides, please email us at info@cancersupportla.org. I put that email in the chat, so shoot us an email if you'd like a copy of the slides, and we're happy to send those to you. I want to thank Dr. Freedland for his time, just for sharing his expertise with us today. And I want to thank you, our participants, for engaging in this presentation today. If you want to learn more about Cancer Support Community Los Angeles, you can visit our website, cancersupportla.org. And if you have any other questions, go ahead and email us at info@cancersupportla.org. Have a great rest of your day, everyone. Thank you so much for joining us. Take care. Bye.
Thanks, everyone. Bye.